This time on the Plutopia podcast, John hosts a panel discussion featuring members of the Society for Participatory Medicine. The Society seeks to bring together all of the stakeholders in healthcare: patients, caregivers, healthcare professionals, payers, and others. They seek to encourage collaboration, communication, and cooperation that will foster provider-patient engagement, patient empowerment, and education.
Hey, welcome to another episode of Plutopia. We have a small crowd here today, and we're going to talk about participatory medicine, and we're also going to talk about COVID. Participatory medicine is a movement in which networked patients shift from being mere passengers to responsible drivers of their health, and in which providers encourage and value them as full partners. That's the canonical definition of participatory medicine. And we talk about the patients who are so empowered and connected as e-patients. Now, in 2006, my friend Tom Ferguson, MD, asked me to attend a retreat with a group of physicians and others he'd been working with on a white paper. And the white paper was published actually after he had died in 2007 as E-Patients, How They Can Help Us Heal Healthcare. He referred to this group as the E-Patients Scholars Working Group. Tom died not long after that retreat, and I continued to meet with the group. So we went on to found a Journal of Participatory Medicine and the Society for Participatory Medicine, which is a very active and I think thriving set of people who are having ongoing discussions about the e-patient and participation in healthcare. We've continued to meet regularly over the years, and we stayed in touch via an email list. So I invited the members of that group to join us, to introduce themselves, talk about how they became involved in participatory medicine. And we're going to start there, and then afterward we can talk a bit about participatory medicine in the era of COVID-19. So first, Joe and Terry Graedon. Terry, why don't you go first and then Joe?
Well, I think actually we should do it in the other direction, because Joe was the first one to meet Tom, and Tom was our introduction to participatory medicine, even though we didn't quite call it that at that original time.
So I met Tom by phone back in 1976, 1977. He had come across our book, The People's Pharmacy, which was all about participatory medicine. It was about people sharing home remedies. It was about people learning about medications. Up until then, pharmaceuticals were kind of secret. There was this thing called the PDR, the Physician's Desk Reference, and it was secret. I mean, you couldn't buy it in a bookstore. Doctors would pass it on to patients or friends, but you just couldn't have access to it. And Tom said, "Hey, I have this thing called Medical Self-Care Magazine. Would you like to contribute?" And medical self-care was sort of the first idea before the concept of participatory medicine. So it was all about getting healthcare professionals to share their wisdom with patients and kind of give them the inside scoop, the secrets of how to deal with all kinds of health conditions. And that was really the beginning.
So Joe was really focusing on sharing what healthcare professionals might know, particularly about medications, because he's a pharmacologist. And my contribution was to say, actual people, they're doing things. They know stuff too, even though it hasn't been written up in medical journals. Let's make sure we find out what they know, what they're doing, and help them share it with each other. And so that was, because I'm an anthropologist, that was my contribution to the effort.
And I think Terry helped us move in the direction of people's experiences being shared, kind of crowdsourcing, if you like. Up until then, if it's not a double-blind placebo-controlled trial, it's worthless. But Terry taught me the value, as did Tom, of people's experiences and how that kind of shared wisdom could be incredibly valuable.
And did you mention the People's Pharmacy?
Well, that was the vehicle. In those days, of course, it was a book, and by 1978, it became a syndicated newspaper column, and now it's a syndicated public radio show heard on about 200 public radio stations around the country. And of course, it's a website and
a podcast.
And a podcast. And we're still basically up to our elbows and armpits in self-care and participatory medicine.
Excellent. Thank you. Gilles Frydman.
So I met Tom, I think, in 1996 at a conference at the Computer Museum in Boston, where I was told that I should go to that conference because there would be interesting people from the various universities around Boston, including some healthcare professionals that had an interest in self-care and empowered patients. And in 96, I was building something called ACORE, the Association of Cancer Online Resources, which had already started to build quite a few online listservs, online communities for different kinds of cancer. And the moment I met Tom, it was just like a magical moment. I suddenly found a doctor that understood exactly what I was talking about, which was better than the other doctors I had talked to before him, who all told me that I was completely crazy and that nothing would ever work and that it was very dangerous. And I will stop there because our friendship grew tremendously over the years until he passed away. And we never had a bad interaction. Never. Not once. Not one sentence.
That's great. Next, John Grohol.
Yeah, hey, I met Tom in the early 1990s when he was researching one of his books about internet resources for health. And, you know, the kinds of patient resources that were available in the 1990s, the early to mid 1990s. And he wanted to know more about mental health resources. And I was a great supporter and organizer of the a website that tried to track the all the support groups that were available online at the time for mental health concerns, for chronic diseases, for healthcare and health conditions. And that's how we met. And he was really fascinated by the fact that, as was I, that people were using the internet for emotional support, for exchanging information about health conditions and mental health conditions, and especially for conditions where in mental health, especially back in the 90s, people didn't feel super comfortable talking about these kinds of things with other people, even with their own healthcare professionals. And so the internet really opened up the door to allow people to have that communication and to share their stories about what was going on in their lives, and share information about very basic information about like what the symptoms of depression were, what the symptoms of anxiety disorders were, because this was protected information. This was not information widely available to ordinary people. So that's how I met Tom, and it was a great collaboration back then to be able to contribute to his work in this field, and to also meet all these other great advocates and leaders in the field.
Alan Greene.
So my first introduction to participatory medicine was actually before I even got the medical degree. I'm a pediatrician now. And I had learned emergency medical technology, and I was helping out a woman in Guatemala in the northern part of the jungle. She's a nurse that was the healthcare provider for 100 square miles. There was nobody else. She was the hospital, she was the clinic, she was the doctor, nurse, midwife, everything for this. And she'd had no vacation for like a decade. And so I had volunteered to go there and help out and fill in. She trained me a little bit and she took off. And I thought I knew plenty to manage the urgent care things there. And I was so out of my depth and realized that it was the community that had a lot of the knowledge. It was especially the wise women of the village that knew so much more than I did about many things. And I knew some, and together we cobbled it together, and it was really powerful and really participatory. So I carried that sort of idea of there being value in what somebody who devotes their life to studying health knows, and value in what the community knows on into my medical career. And early on, my wife and I launched a website, drgreene.com, back in 1995, that was really dedicated to giving tools to parents to be primary care providers for their kids, and to listening to parents, as Terry was saying before, gaining wisdom and sharing it back and forth. And then first met Tom at the Internet Health Day, Intel Internet Health Day 2, back in the 90s, when he was awarded the pioneer hero of the internet, of the health internet. And I got this thing for being the kids health hero. And we made a beeline for each other because I'd been following him. He'd been looking at us as a web resource. And we started talking, and just heart-to-heart connection, and then introduced me to this cast of characters that's here together, and have been together ever since.
Oh, thank you, Alan. Next, Charlie Smith.
Yes, like so many of the others on the call today, and perhaps all of us, my entree to participatory medicine was through my relationship with Tom Ferguson. And it was a bit later, perhaps one of the most recent of all, in that Tom had been diagnosed with multiple myeloma and was being treated at University of Arkansas, where I spent most of my professional career as an academic family physician in the Department of Family Medicine. And I, at the time, this was in the early 2000s, I believe, when he was coming there for treatment. And he was putting on a program for the public about how the patient could take responsibility for their own health care as he was being treated for this horrible disease successfully at the time. And it was just a real eye-opener for me to be at that presentation. And after the presentation, I ran up to the front of the room, because at the time I was starting and trying to build one of the very early internet health companies called eDoc America, that allowed patients to log on and get information that allowed them to manage their own health care. And so I was naturally very interested in getting to know Tom. And so we struck up a relationship, and like others, he introduced me to the group that's on the call today. The other thing that we talked a lot about was patient feedback. And he was a champion of this idea of the index card feedback form that you would give to providers, because he believed, I think correctly, that no doctor-patient or professional-patient relationship could be successful without feedback from the patient to the professional. And so working with Tom, we actually introduced something called the one-page feedback form throughout our institution that I believe helped revolutionize the care process at UAMS, and to really bring the providers into a reality that they hadn't known before about what their patients actually thought about their care. And so it was really a wonderful turn in my career to meet Tom and meet the rest of the group here. And it's been good since.
Thanks, Charlie. Danny Sands.
Okay, I just had to unmute. My background is, I did work in information technology first, and I went to college not knowing what my career should be. I was thinking about medicine. I was thinking about a field of engineering. I was even thinking about law. I ultimately chose medicine. And but because I had this technology background, I was frustrated by the fact that we weren't using enough technology as part of the way we provided healthcare. And I thought that was a hazard, and it was really ridiculous. It was inefficient. So I became motivated to improve the way we use technology so we can improve healthcare. So it was about providing tools for clinicians. So I went through my medical training. I trained in internal medicine, and then I did additional training in clinical informatics, which I did at Beth Israel and Harvard. And while there, I had this weird epiphany, which is that I was in the process of developing tools for clinicians at the point of care. But one of the things I discovered in my own practice as I was taking care of my primary care patients is that these information technology tools could be equally and even more empowering to patients and caregivers. And the earliest example of that in my own practice was using email with patients. And this is in the early 90s, which of course took off in the mid 90s when the web hit the scene. But I was using email with my patients at a very early time. And I ultimately co-authored the very first guidelines on how to use email with patients. But through that work and my talking about this stuff, and then later co-developing one of the nation's first patient portals, I became acquainted with Tom Ferguson. And I can't remember if he approached me directly or if he was introduced to me by Warner Slack, who many of us know. Sadly, of course, they're both deceased now. But we met at that time, and that's when Tom pulled me into this group of people, the e-patient scholars, who were meeting annually to talk about their vision of healthcare and how healthcare could be better, and to talk about all the cool things that we were each doing to make healthcare better. So that's really how I became interested in this. I was motivated to do clinical informatics because of tools for clinicians, but then my career shifted and I became involved in how these same tools could be empowering to patients and caregivers.
Thanks.
Are we good?
Cheryl Greene. Yes, let's go with Cheryl Greene.
Hi, I'm Cheryl Greene. I'm the co-founder of drgreene.com and of Bambini Fortuna. I came to this whole movement as a patient, and I think that's a very important voice for this whole group. And I became an empowered patient when I had a very serious diagnosis. I had been an infertility patient, and when our baby was 9 months old, I was nursing and found a lump in my breast that was diagnosed very quickly, actually within 6 weeks, to be stage 3 inflammatory, high risk, triple negative breast cancer. And that started us into about 2 years of very intense treatment first, and then also a clinical trial. And during that time, I learned that I had information that my care team needed, that if I didn't provide that information to them, they were being handcuffed. They couldn't do their jobs properly. When I started this whole process, starting as an infertility patient, I was very, I was compliant. I was the good patient. But as I went through it, I realized that just being compliant wasn't the goal. The goal was to be part of the team, to do my part, and to make a real difference in health. So that's where I was when we met Doc Tom in 1999, as Alan has discussed. We met him at the Internet Health Day, and I was ready to go because this is an important topic.
Thank you, Cheryl. Dave.
I was going along through life, and around 2000, I decided I did not want my PCP anymore. And I asked a college classmate who was CEO of Beth Israel at the time if he knew of if he had any PCPs. And he said, well, we've got this guy, Danny Sands, who you might like. And so, because like he does email with patients, and I thought, well, that's cool. And as it happened, shortly after that, I moved to Minnesota and came back a few years later and said, can you take me back? And at our first physical that year. To make a long story short, I had a sore shoulder. I got a shoulder x-ray that disclosed a tumor, coincidentally dumb luck, in the shoulder or in the lung next to the shoulder that turned out to be stage 4 kidney cancer. As it happens, after the diagnosis was confirmed, he literally handed me a slip of paper that I remember as a prescription slip. It said ACOR on it. He says it wasn't a prescription slip. Anyway, I like to say my doctor prescribed ACOR and it saved my life. And that's where I ended up meeting Gilles Frydman. The thing is, so during my cancer year of 2007, at diagnosis, the best available data said my median survival was 24 weeks, and that is sobering. And the only treatment available at the time that could cure somebody, high-dose interleukin-2, had side effects that sometimes kill you. And I asked my oncology team, anyway, it turns out the patient community on ACOR for kidney cancer was full of, up to the minute, it was a full expression of Tom's vision, even though I'd never heard of Tom. From them, I got advice on how to survive the side effects that my oncologist said, he later said, he believes helped save my life. And so it was funny to me when a year later, in the same way John got invited to go to the 2007 or 2006 gathering of this group, I got invited to go, and Danny told me about this publication, and I've become a collector now of all the artifacts I can find. I don't know if my Zoom background is going to cooperate here, but this is Tom's white paper that this group finished. And a year later, I got thrust onto the front pages of the newspaper because I started looking into the data that my hospital had in the computer. It turns out that my billing data was all full of insanity. And I ended up becoming literally a global evangelist for this movement and these people, because I worked in marketing before cancer and I knew how to give speeches, and one thing led to another, and 600 events later, I now have retired from that. And I'm thrilled to say two things. First of all, just to wrap up. In 2012, the Institute of Medicine published this book, Best Care at Lower Cost, which it's actually a 500-page book. This is a summary. In its summary table, we knew that as a movement, we were making progress, because I made no bones about it. I was in this for a social movement, social change. The Institute of Medicine said that of the 4 characteristics of the future health system, second on the list, right after science, was patient-clinician partnership, engaged, empowered patients. Now, I thought, that's it. Okay, medicine will turn around and say, okay, we were wrong, and start doing things differently. No such luck. But now we know the biggest part of my crusade, one of my rallying cries was, give me my damn data. And now the latest federal rules out of HHS, the so-called final rule of the 21st Century Cures Act, mandates that all the data in EMRs is going to have to be available to patients through APIs. So software apps can be developed to let us have all that information. It won't make us doctors, it won't solve everything, but at long last, we'll all be able to see everything that's in there, fix all the mistakes, and be on something of an equal footing. So I'm grateful to this movement it wasn't just dumb luck that I got connected with Danny, who connected me with ACOR and Gilles because of Tom. There's no question I'm alive because of Tom. I'm happy to be evangelizing it. So I could go on.
Thank you, Dave. Before we talk about COVID or get into COVID at all, Gilles, I'm wondering if you could sort of explain a little bit more. You mentioned ACOR and Dave mentioned ACOR. Maybe you could explain exactly what ACOR was and how it worked.
Sure. So I'll start first with my personal story, the reason why I started ACOR, really fast. my wife was diagnosed with cancer in an institution that I knew really well because 7 years before diagnosis, she had 2 open heart surgeries. And I completely trusted the cardiologist who became the family doctor. And I learned a really hard lesson that a great cardiologist, a great family doctor, when he's in an institution that doesn't know anything about cancer, is not able to refer you inside the institution to the right doctor. What should have happened was to refer us immediately to an outside institution because his institution was not the right place to get an appropriate cancer diagnosis. So we had incredibly great cardiac care 7 years prior and incredibly bad diagnosis of what turned out to be very early stage breast cancer. And thanks to the internet, within less than 2 hours, I had enough information to call the surgeon that had given the diagnosis and wanted to give a very harsh set of treatments. I told her that we were going to go for a second opinion. And this is the first time in my life that we were fired as patients. The doctor said, if you're going for a second opinion, you're no longer my patient. Have a great day. It turns out that it was the best gift she could give us because thanks to the internet and the information I got through a listserv, my wife didn't have chemotherapy that was completely unnecessary. It probably would not have done anything good, but would have certainly done a lot of very negative effects. She didn't need to have a full mastectomy, and she only had a lumpectomy. And as a result of this experience, I decided to stay on the listserv for breast cancer and pay attention to what was happening around the internet. I found that, like, all of a sudden, there were 9 new groups that were created within a month in September 95. And I found out that there was conversation that were like really at a very high level were never archived. So all those amazing conversations disappeared if you are not following them in real time. So the first thing we did was to create the first archive of cancer listservs. And then 6 months later, we created a not-for-profit, and we created a little over 200 of those online communities for all kinds of cancers. And by the end of FACOR, we had served over 1 million people, and we certainly saved the lives of tens of thousands of people, including a large number of people with rare cancers. We were a fundamental tool for rapid accrual, very rapid accrual in the early clinical trials for what was at the time revolutionary cancer treatments, the first targeted therapies. And I mean, I could go on and on for like 2 hours about what happened with ACOR. What I can tell you is that we didn't plan any of it. The only thing I knew was that I studied science early in my life, and that if my name was associated with online communities, they had to be a conduit for science and real information. And so we developed a whole bunch of policies to make sure that those communities were not used to promote bad science, snake oil, etc.
Yeah, that's part of the trick, isn't it?
Yes. In fact, the issue is almost not at all technology. The way to build those great communities is not to have super technology. It's all about sociology. And I think that in most of the issue of social media, it's the same thing. No one is paying attention to the sociological issues, and everybody's like thinking that technology will resolve everything, when in fact it cannot resolve issues between human beings.
Yeah, people have to resolve those.
Mm-hmm.
Well, thank you, Gilles. Dave, are you? I wonder if you're there. we were going to talk now about COVID a bit, and you had something that you wanted to mention about someone that you had met at a conference. Do you want to talk about that now?
Well, yes, and I assume you're going to publish notes along with this whole episode, so you can include
We
the link.
can, yeah.
Yeah. So I actually worked with this woman. There is a whole category. So as we're recording this around Thanksgiving 2020, and heaven knows what this will all look like 6 months or a year or 5 years from now. But there is an emerging problem that has only become known in the last few months of what they call long COVID, or some in the US, I guess, but not outside the US. They're also known as long haulers. It's patients with COVID-19 who don't get better, or they get better and then they recur. And Dr. Anthony Fauci, a couple of weeks ago, speaking to the AMA, who right now is the head of infectious diseases for the US, he said that the latest NIH studies say it's 25 to 35% of all COVID patients that end up in this category. In fact, Alan, I think the last time we all met, you mentioned some very strange persisting symptoms. Anyway, the woman who spoke is a woman named Hannah Way from Ottawa in Canada, who is a member of one of the numerous e-patient communities that has started up. Apparently there's a 100,000 member Facebook group. There's a group in the UK called Long COVID SOS, which is directly addressed to Prime Minister Boris Johnson saying, yo, you're not hearing us, we're not getting taken care of. Hannah's group is called Body Politic, and they have a 9,000 member Slack community there of long COVID patients. And their experience over and over and over again has been, in the early months of this pandemic, medicine was still trying to figure out anything about this disease, and they weren't getting heard at all. Hannah told her story of going to the ER and basically being told there's nothing wrong with you. And they have this great slide in her talk of a hand coming, sinking hand in a pond going down underwater, the doctor's hand reaching out and then saying, your test results are normal, high five, and the hand sinks below the water. All right. And so what they're doing is they've banded together and they started researching themselves, patient-led research. And the first self-created study that they published in May got lots of publicity. It was on NPR, ended up in being reported in the BMJ Open and numerous other places, and has become the cornerstone. This patient-created, patient-led, patient-defined research has become the cornerstone of what people build on to better understand long COVID. They have another survey that they're just working on. So this 15-minute video, it was inspiring to me, and I thought, how fortunate am I to have the Tom Ferguson background and all of this to put context around what these patients are doing. And it seems that they're finally getting heard. I mean, when Fauci tells the AMA this is real, it's like, God bless the internet.
All right, thank you, Dave. So my question now is, who would like to speak? Who has some insight into COVID? Have something to say about it?
Could I
Yes.
follow up on what Dave was just talking about?
Sure, Gilles.
So the people that are in those long COVID communities are experiencing something they never experienced before. And so they are sure that what they are experiencing, it's the first time it is happening. But that's not the case. If I tell you something, if I tell you brain fog and chemo brain, I think that in 2020, there is very few people that have not heard those terms. But when we started ACOR in 1995, invariably, people that were taking those very harsh chemotherapies were reporting something that they had learned within the groups was called chemo brain. And they invariably reported that their doctors were completely in denial of the existence of this condition, which of course in 2020 has become completely accepted. So the fact that patient communities are able to very fast report effects of diseases and side effects of treatments to the point where if you pay attention, there is no doubt that they're reporting something that is real, is a defining feature of those online communities. And I think that the world of medicine would greatly, greatly benefit if it paid close attention to what is happening in every time there is a new disease, an explosion of communities. It would advance knowledge so much. I have been part of the long haulers community on Facebook for more than 3 months now. So I've seen it grow to, it's now, I think, close to 150K members. And unfortunately, even though I said technology is not important, it turns out that technology is very important for one thing, which is the human computer interface. And the Facebook interface is absolutely not designed for in-depth medical conversation. So you have this huge community on Facebook, which in the numbers tells me that it should be a source of incredible information, but because of the interface, I think its benefits are inherently limited.
Thank you, Gilles.
I'll stop there.
Dave, you're unmuted. Did you have a follow-up?
I just wanted to note one line. Sometimes I feel like an evangelist going around quoting scripture, you know, the one line from the white paper, which is so one member of one patient group who said, we're lab rats tapping out signals on the bars of our cages. You know, the patients getting together and saying, yeah, I hear that. I know what you're talking about, right? And this profoundly challenges the traditional view of how legitimate knowledge is discovered, comes into existence. The traditional view is that it goes through science, which I certainly am happy for, but it can also arise from the grassroots today, something that was really not feasible 50 years ago, but we're seeing it all the time now.
I see that John and Danny are both unmuted. How about John, you go first and then Danny after John.
Yeah, hey, I just wanted to chime in here and talk about the what a lot of people are experiencing from a mental health perspective, which is COVID fatigue and pandemic fatigue. We're all you know, getting super tired of having to adhere to the different you know, conditions that exist in each state and lockdown. And you know, I think that's what contributes to a lot of people's frustrations about complying with public health officials' decrees about, you know, staying at home and not engaging in public activities or expanding your bubble during Thanksgiving, is that people are just frustrated. From a mental health perspective, it's become very frustrating as the science, you know, continues to try and catch up to what the policymakers are doing. And I think it's been, from that perspective, you know, very tiring for many people and very fatiguing. So I think that's an important point that I just wanted to chime in with.
Great. Thanks, John. And Danny, and then after you, Cheryl.
Yeah, let me build on that. I don't want to, you know, I think that all these conversations are very important as we talk about, you know, COVID and the role of patients. And, you know, it's very interesting, John, because that observation is obviously spot on. And I'm seeing a lot of it in my practice. You know, we've gone from a time when people's emotions are at sort of 11 because of, you know, racism and the political discourse and blah, 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 all this stuff. And it's just at 11. And then this COVID comes along and just knocks them right out of the park. And it really is a huge impact. So they're going from, you know, Trump dysphoric syndrome to now this COVID thing, which is just all encompassing, and people are terrified, and you know, it affects everybody. It's affecting me. You know, we're trying to decide if we want to have, we only have 2 kids, and one of them lives in Boston. We see her frequently. The other one lives on the West Coast, and we're having a lot of anguish over whether or not she should be coming home for Thanksgiving. But not to minimize it, because my patients are through the roof with anxiety related to COVID. But I wanted to bring up a whole nother aspect of this. So the COVID pandemic has pushed us to adopt technologies at a much more accelerated pace than we would have normally adopted them. So you see this publicly with the development of vaccines. This has never happened before. We've developed vaccines so quickly. But you know, I'm a health information technologist, and to me, what's been interesting is that you know, if we look at things like telemedicine, the way we deliver health to patients, so back in the 90s, I started writing about how email, asynchronous communication, is actually a way you can take care of patients with their problems. And then I went on and talked about, you know, later went on and talked about how telemedicine could be useful, but pushing the healthcare system to adopt telemedicine, both on the patient side and the healthcare professional side, has been quite challenging. But then along comes COVID, and it's not safe to see people in the office. And all of a sudden, we're pushed to change what we do. Patients don't want to come in. We don't want patients to come in. And this has impacted everybody. So, of course, it's driven by reimbursement. So health plans are paying for this now, but they're paying for telephone care. They're paying for video care. And it has caused us to adopt these technologies so quickly. In our own practice, which is a very large academic medicine practice, that includes mental health, by the way, we had to basically turn on a dime, and over the course of a weekend, we transitioned to 100% face-to-face care to almost 100% virtual care. And now, of course, we're swinging back. But this has happened all over the country, and this has been huge. I mean, now in the Boston area, I can tell you, based on my patients' experiences, it's way easier to get an appointment with a mental health professional of any kind virtually than it is to get a face-to-face visit. So that's one set of things related to the technology. But let's think about it from the patient's perspective. So this has lowered the barriers to have them seek out a healthcare professional, mental health or regular anything, right? So yeah, you can't get surgery this way, and you can't go to your dentist virtually, and so on. But how many patients would be uncomfortable walking into a therapist's office? How many patients struggle to, you know, take public transportation to get to my office to see me? And now all of a sudden, it's easy for them, right? It has really lowered those barriers, and it's allowed these patients to have a connection to the outside world, to discuss their anxieties, to manage their healthcare problems. So I think this whole impact of COVID-19 has been very, very interesting. And I believe that, you know, the genie is out of the bottle. We're not going to go back, and it's going to be very exciting for all of us.
Thanks, Danny. Next, Cheryl, and then Graedon's, and then Alan.
So I have a very diverse Facebook friend group, intentionally. I have people across the political and socioeconomic spectrum, and partially because I really want to hear a variety of viewpoints. And one of the things I found incredibly interesting, also frustrating, is that among my Facebook friend group, there are people who are COVID deniers, that they still don't see this as something that could happen to them. And their whole approach is, we need to open up. Small businesses are going to die. We need to get kids back to school. We need to be normal again. And it's really highlighted the importance of participatory medicine and participatory health, that there are tools that we have that, if we will use them, can help. You know, wear a mask, social distance, don't go in indoor dining, no big groups, those kinds of things. But for the people who are denying it, those are the things that they either don't want to wear a mask or they do want to eat indoors. And so the message of participatory medicine and actually being responsible for your health is even more important during this time than ever.
Thanks, Cheryl. Next, Graydon's, and then Alan, and then Charlie.
So I just want everybody to remember that Tom Ferguson predicted all of this 30 years ago, 20 years ago. I mean, he was sort of imagining patient consultations by phone and then by internet, and doctors prescribing by internet. And I used to fight with him about that, and then he converted me to a great believer. Tom, in all those presentations, had a pyramid. And if you remember, the old way had the physician specialists at the top, and then the doctors, and then eventually at the bottom of that pyramid were the patients. And he just turned it upside down and suggested that patients really were the resource, and that you eventually might end up with a specialist, but patients and families were really where people turned to for the early stages. And I think what Gilles is describing in terms of the long haulers, or the long COVID, as Dave said, I mean, that's how patients have connected with one another and have identified, hey, this is real. And it's not just one or two of us, it's tens of thousands of us. And the same thing actually has happened with chronic fatigue and Lyme disease and fibromyalgia and a lot of the conditions that have been very hard to really understand what the mechanism is. And I think what Tom was always trying to do was level the playing field and encourage physicians to listen to patients and to pay attention to their experiences, even if you might not understand or be able to explain them. So Tom really was way ahead of his time. And Terry has an artifact. Dave was showing us an artifact. So this was a notebook that we had just found this afternoon as we were getting ready for our talk today.
I picked up a pile of papers off my desk, and at the bottom of it was this notebook in which we are taking notes on planning how we are all going to put the white paper together, because in fact, Tom died before he had the white paper fully organized and ready for publication. And we, his friends, all of us here, except for Dave, who came along later, along with a couple of other people like Susanna Fox, actually organized all the hard work that Tom had done and got it into publication shape. And that was the notebook we were using to do that organizing. I did want to say something about COVID and its impact. And I guess what I wanted to say is more about a little bit related to what Gilles was saying, somewhat related to what Cheryl was saying, in that what we have seen on our website is that the social media at this point in time seems to exacerbate people's original ideas. So if you're a COVID denier, you're going to seek out places where that is reinforced. And if you are not a COVID denier, you go to places where you're going to get reinforcement for your perspective. And I think that is, unfortunately, really difficult to counter.
Okay, and now Alan, and then Charlie, and then Danny.
Terry, that is a tough one. My favorite audiobook of this year so far has been Mistakes Were Made, But Not By Me, which is a brilliant book. And there's a 2020 edition explaining all the different mindsets people have today. You could almost subtitle it Mistakes Were Made, But Not By the Healthcare System. And it's an interesting read. But the thing I want to talk about real quickly is that when I started in medicine, the center of gravity of the medical system, the visible medical system, was the hospital, the medical center. It's where the important things happened and where the big decisions were made and the complex issues were solved. And over the course of my career, I've seen that center of gravity shift to the outpatient world, to clinics and to doctors' offices. And the billing system has been set up to support that. People are, the providers get paid, doctors get paid for when people come into the office. And with COVID, all of a sudden, like overnight, finally, they're trying to get people not to come into the office. And it's turned that bit upside down. And the center of gravity has shifted to the patient's home and to where they hang out. And I think that's a brilliant thing. And the reality is it's been there all along, as Tom's triangles have shown. That's where the consequential decisions are made day after day. And much of the choices that impact our long-term health are happening. So my hope is that Tom's, what were upside down triangles or pyramid, will now become matching triangles, that the healthcare system will start to match where it's really happening in the lives of people overall. It's accelerating really important change.
Okay, thank you, Alan. And Charlie, and then Danny, did you have something? Oh, okay. So Charlie and then Gilles after Charlie.
Yeah, thank you, John. I just wanted to make a couple of quick points. One is, in observing Tom, if I didn't mistake him, he advocated for a informed collaborative relationship with his professional physicians. And at the very best, in my view, as a physician and as a patient, this participatory medicine idea is best exemplified when an informed and empowered patient is connected with a physician who is receptive of that informed, empowered patient. And I think the patient, on the other hand, it's a good thing to remind patients that they can train their physicians to be that way if they don't start out that way. And so I really just wanted to throw that point in. And the last thing I wanted to say on my time is that as a parent of a disabled child in a nursing home, it's important to remember that there are a lot of what I would just call disempowered and disenfranchised people in the world, disabled people who may not be able to speak or see or hear. And it's difficult, if not impossible, for them to advocate for themselves. And as just one harsh example of what's going on in nursing homes, 8% of the patients in the nursing homes are accounting for 40% of the deaths of COVID. So 40% nationwide of the deaths from COVID are coming from the nursing homes. And those are the poor souls that really are stuck behind the door and can't really do much other than sit there and hope that they don't get COVID. So we just need to remember, I think, those disempowered people out there and help them along as well.
Thanks, Charlie. Yeah, my daughter is director of nursing or assistant director of nursing at a nursing home. And I've been getting some play-by-play there. And one thing that I'm hearing, there's been kind of a surge of nursing home COVID cases recently. And apparently, probably because of COVID fatigue, it's just been like lapse protocols, people failing to wear masks when they should, that sort of thing, like staff. Gilles.
Yeah. So when we started, Tom started 30 some years ago. I started 25 years ago. Most of the people in this group started between 30 and 25 years ago. When we all started to work on this issue of like empowered patients, activated patients, we were fighting against a system that basically totally refused the value of those patients. At this point, I think the system does not fight it. The system quite accepts it. But the fight is not over. Now we are facing this disease that is completely misunderstood. I think it's going to take years before we understand what are the myriad of impacts that this disease that ends up being a vascular disease for the long haulers. We don't know what it is. We just know that we are going to have millions of Americans that suffer from long-term effects of a disease that is very poorly understood. So one thing that is going to happen, you are going to have those huge online communities, but I'm not satisfied with online communities at this point. If we cannot connect the online communities directly with the data that is collected from those patients in the medical system and in the research system, we are going to miss the next great opportunity. I think this is where it's going to go. And that means direct collaboration between patients and physicians and researchers. So I think that this is where our great evangelists should start working on, like, really hard now.
Okay, thank you very much, Gilles. We're just over an hour now. Does anyone have any concluding remarks? Seeing none, I want to thank you all very much for joining us today. I think this has been a terrific conversation, and I just want to mention that the Society for Participatory Medicine is at participatorymedicine.org. Anybody can join and should join, because I can't imagine there's anybody listening to this who is not a patient. So thanks all, and hope to see you soon, physically somewhere in better circumstances. Right?
Thanks.
You can follow the Plutopia News Network at plutopia.io. On Facebook, go to @Plutopia News. On Twitter, it's @Plutopia. With John Lubkowski, I'm Scoop Sweeney. This is the Plutopia News Network, 20 minutes into the future.